Good morning, good afternoon, and good evening. Women of Color in Pharma is excited to be hosting this historic panel for us to talk about this pandemic that we find ourselves in the midst of. And prior to introducing our panelists, I would just like to give a few remarks for those of you who are unfamiliar with Women of Color in Pharma. Women of Color in Pharma is a global professional society that was founded in 2015 by myself and Patricia Cornett. Along with that, we had 7 other founding members. Today, we have over 350 members, and our network continues to expand, including among over 3,000 on our social media channel. We are sponsored by corporations, and we have over 12 companies that have sponsored us. In the past 3 years, we've had a lot of impact, and our vision is really to enable the transformation of the pharmaceutical landscape by illuminating pathways for women of color. Our mission is to empower women of color in pharma who to excel in their personal and professional development as they transform their pathways and seek roles of impact. So today, as I mentioned, we're all here. We find ourselves in the midst of a pandemic caused by a new coronavirus. It is causing significant health issues and disruption to our global economy, and you may say to your household as well. And it will have the potential, and we know it will have a lasting impact on our society. You may wonder, what is a pandemic? You may be hearing about this. It's really a global outbreak of a disease. It happens when a new virus that has the ability to infect people emerges. And because there is little to no immunity, meaning the body's ability to fight against that, we see that it has the ability to spread from person to person in a rapid way. And we are seeing that. In our past century, there has been 4 pandemics that have emerged by the influenza virus, but this is the first one that has emerged by the new coronavirus. And this map really says it all when we talk about a pandemic. You can see, and I find myself going probably multiple times throughout the day to this site at Johns Hopkins that they've put on that really shows the widespread effect of this disease. These were numbers from yesterday, so it would not surprise me if you go to the site today that these numbers have increased. Just a few basics about coronavirus. COVID-19 is the respiratory disease that's caused by the new coronavirus that hasn't previously been seen in humans. Coronaviruses are a large group of respiratory viruses. They cause illness in people and occur in animals, including camels, cats, and bats. Rarely do animal coronaviruses evolve and affect people, but we're seeing that has happened now. So in the next hour or so, what our panel of physicians that we've gathered are going to do is give you some firsthand account of their experience with COVID-19. They are all on the front lines, and we want to hear from them in terms of their experiences. We're going to discuss myths about the virus. We're also going to talk about how this virus is spread and also understand what these physicians are encountering both on the front lines, but also how they're dealing with this in the midst of their lives, because this has, as it is impacting your life, we know it's also impacting their lives. Before I get started, I do want to introduce each of the panelists to you. I want to thank them for their service and taking care of all of us during this time. Our first panelist is Dr. Geoff Moorer. Dr. Geoff Moorer is a medical oncologist with the Virginia Cancer Specialist. Geoff was trained at the University of Maryland Medical Center and did his fellowship at Columbia University in New York, which we know is the epicenter in the United States. Geoff was a top doctor in 2018 and 2019. We welcome you, Geoff.
Good morning, everybody. Thank you for having me, Charlotte.
Absolutely. Our next panelist is Dr. Thalia Palmer. Dr. Thalia Palmer is a pediatric anesthesiologist. I'm just going to flip to my phone so that I could get her training. She's an assistant professor at Rutgers, Newark. So she's also very close to the epicenter. Dr. Thalia Palmer was trained at University of Michigan. She did a pediatric anesthesiologist fellowship at the Children's Hospital in Boston. Welcome, Dr. Thalia.
Thanks. Hi, everyone.
Our next panelist is Dr. Abena Osewusu. She is a cardiologist and senior clinical trial physician at Bristol Myers Squibb. She did her training in cardiology or internal medicine at University of Maryland and a fellowship in cardiovascular diseases at the University of Pittsburgh Medical Center. Welcome, Dr. Abena.
Good morning, everyone. Thank you for having me, Charlotte. Thank
you. Our next panelist is Dr. Allison Agwu, who is the Associate Professor of Adult and Pediatric Infectious Diseases at Johns Hopkins University School of Medicine. Dr. Agwu did her training at University of Maryland. She did undergrad at University of Maryland and medical school there. And then she did her internal medicine pediatric residency at Case Western Reserve University and an adult and pediatric ID fellowship, infectious disease fellowship at Johns Hopkins School of Medicine. Her clinical and research interests are in HIV/AIDS, and she has a focus on youth and young adults that have HIV. Dr. Allison, welcome.
Thank you. Good to be here.
Our next panelist is Dr. Janine Adjo. She is the chair of Department of Pediatrics at St. Barnabas Health System, which is a community hospital located in the South Bronx of New York. So she is in the epicenter. She graduated from SUNY Downstate Medical Center and completed her pediatric residency at New York University Medical Center. Dr. Adjo, welcome.
Thank you very much, Charlotte, for having me.
And our last panelist is Dr. Ian Martin, who is system chairman of the Department of Emergency Medicine at the Medical College of Wisconsin in Milwaukee. Dr. Martin is also emergency physician in chief, as well as the president of the Society of Academic Emergency Medicine. Dr. Martin earned his medical degree at the Medical College of Pennsylvania and Hahnemann School of Medicine. He then did his training in emergency medicine and internal medicine at the University of Maryland, where he was also chief resident. He then moved to North Carolina and was at UNC. So welcome to you, Dr. Martin.
Good morning, everybody. Thanks for having me.
Great. So we're going to go ahead and get started with our discussion today. And I'm just going to open it up and have each of our panelists, you guys are in very different areas of the country, but all of you are on the front lines, as I've mentioned. And I just want to get a sense of, what each of you are encountering. So I'm going to just kick it off with Geoff and have you just talk to us a little bit about, in your practice, in terms of the patients, what exactly are you seeing?
So once again, thank you for having me, Charlotte. Good morning to everyone. So for those who are not familiar with me, which I would be gathers the large number of the participants, I'm in a large private practice here in Northern Virginia, essentially the DC suburbs, areas like Fairfax, Manassas, Arlington, Reston, et cetera. Most people are probably familiar with those areas as we're located within the beltway of the DMV, as it's now known. So I essentially manage all types of hematology or blood disorders and oncology patients, cancer patients, have a very busy private practice, and also see patients in the hospital as well. So the majority of my patients would fall into what we know as high risk category patients. The average age of my patient population is probably somewhere in the early 60s or so. So that in and of itself is a risk factor for COVID-19 infection. So we are starting to see that first wave of the effects of the pandemic here in Northern Virginia. You know, I was on call in the hospital last week making rounds, and you're starting to gradually see the ICUs fill up with patients who are ventilated on breathing machines, who are either have positive COVID testing or are in the process of being tested. So we're starting to sort of get the beginning of a wave. Obviously, a few weeks behind what we're seeing right now in New York, as you mentioned, is the epicenter, and other areas that have been hard hit, like Seattle and the Washington State area. So in terms of the effects of shortages of personal protective equipment, masks, and gowns, we really haven't seen that as of yet in both the inpatient and outpatient setting in my office. We have ample supplies here in terms of masks, gowns, gloves, et cetera. But there is starting to be some concern from the hospitals and from the offices as well in terms of how we're going to ration those supplies as we're preparing for that wave that most likely will come. So at this point, I would say that, even though we're on the front line, we're well prepared here. We're obviously monitoring the news greatly that's coming out of New York and other places, like I said, Washington State, to hopefully be prepared for this when it comes.
Yeah.
So at this point, I wouldn't describe it as a crisis, but we are cautiously preparing for what is to come.
Thanks. And you see patients that have cancer. Are you making any changes to how you're treating those patients? Do you consider those patients to be immunocompromised?
Yeah, absolutely. So in addition to, the average age of a patient being, 60s, but I treat patients, I probably have some treatment patients even in their early 90s. So by definition, a lot of them are immunocompromised because of risk factors like age, like their disease. Most patients who have cancer would fall into an immunocompromised state, especially your hematologic cancers like leukemia and lymphoma. But then many of the treatments that we're utilizing also do damage to the immune system. Primarily chemotherapy has a significant effect on the immune system, which actually in some instances can completely decimate the immune system and make those patients highly susceptible to infections. Infection is probably the number one complication that we see in treatment of cancer patients. So we're having to adjust in terms of delaying therapies and or decreasing the dose of some therapy. So for instance, there's recommendations now on delaying chemotherapy with targeted therapy, hormone blocking therapies, which can be effective, but they don't put the patient as much risk in terms of knocking down their immune system. Right now, it's really done on a case-by-case basis because we haven't got a lot of direction from our large leadership groups, just because the data is not mature yet. We're at best in the United States 6 to 8 weeks into this pandemic. So really everything that's out there in terms of data is really on a case report basis, individual anecdotes. There's no large body of data to direct us as to how we should be managing these patients, but we're all making adjustments based on our own expertise and background.
Great, thank you for that. And you speak about, there's really no data to direct us. That's what it means to be on the front lines. As data is rolling in, we're trying to pull that together.
In real time.
Yeah, absolutely, real time. So I'm going to switch to our infectious disease specialist, Dr. Allison, because I can only imagine that given that there isn't a lot of data and this is real time, that people are calling upon you and your colleagues for consultation in terms of, what do they do, what are they seeing? Can you explain to us, give us a sense of what it's like for you and your practice?
I think she's still muted, Charlotte.
Oh, Allison, take yourself off of mute, please.
She doesn't know how to do it, I don't think.
Lucretia, can you take her off of mute?
I'm doing it. Make sure
Okay,
she's
great.
don't press any buttons.
Hold on, Allison. We're going to get you. One more time. There you go.
Okay, I thought I was being muzzled. Um, so your question is, what are we doing in terms of treatment?
Well, yeah, we were talking.
Yeah.
Jeff mentioned that given that this is new,
Yeah.
there's not a lot of data, and that's really what it means to be on the front line.
Yeah.
You are seeing things as they come in and trying to do the best you can with the data that you have. Of course, the data that we have is being informed from China and Italy. So as an infectious
Yeah.
disease specialist, I'm sure you're getting the consultations. People are asking you, one, is this COVID-19, what do I do? So can you just share with us a little bit in terms of, what you're seeing and what your day-to-day practice is like in the hospital?
Sure. So I'll take that first, and then I can talk a little bit about what we're doing in terms of winging it and trying to figure things out in terms of treatment. So in terms of my day-to-day, I wear a lot of hats. So as you mentioned, I'm adult and peds ID. I direct the pediatric adolescent HIV/AIDS clinic, as well as the young adult practice. And so a lot of my day-to-day has been trying to, figure out how to manage those patients who are just scheduled for regular appointments to try to move things to telehealth. So it's amazing how we have gone from no telehealth to full telehealth in the space of 2 weeks. It just shows you what you can do when you put your mind to it. However, in addition to that, many of our patients, we think, we're not sure, but we think having HIV, just like Jeff mentioned, being immunocompromised in some way, may increase your risk of COVID. We don't know that for sure, but the suspicion is there. So trying to triage who actually needs to be seen and where they should be seen to keep them safe. I also run the pediatric adolescent maternal clinical trials for HIV. And so trying to keep people, because there's studies going on to try to maintain people. And then I wear my peds and adults HIV, just infectious disease practice hat, where I am essentially involved in rationing testing, because we don't have enough tests to test everybody. So deciphering who should be tested in terms of COVID, because that it has implications for where they should go. So being really on a management scheme in terms of who can we afford to test. And when I say afford to test, because if you test somebody, you have to automatically assume that they are positive. And then you have to have the personal protective equipment, as well as the specialized settings, which is now airborne isolation, to be able to protect others from them. So in terms of the hats, it depends on the day, what's happening, but it really is, it's 12-hour calls and sometimes 24-hour calls in terms of managing what happens. To move to your question of treatment, I think we do have a little bit of the benefit of being behind China and Italy in terms of what things they had done anecdotally, one, and Thalia can probably speak to things that people are doing in terms of how to intubate and best ways to do that. But in terms of treatment, we've had things come forth where there were agents that were used for either Ebola or SARS or MERS from before, that people pulled out and said, well, let's try that again, and just started to use them. And unfortunately, I think in some cases that became, pushed by our higher ups, that this was what was being done when there was no data. So some of the things like Kaletra or lopinavir ritonavir, which is an HIV drug, there was some anecdotal evidence that there would be benefit. But then there happened to now be a clinical trial showing that there actually may not be any benefit. So we're doing that. Remdesivir, which is an antiviral, is now in clinical trials. And reality is, a lot of times when you do clinical trials, it takes a long time to recruit patients. We're not having a problem recruiting patients because it's every day it's thousands of people being added and they're being randomized to either remdesivir or not. And so hopefully we'll know if that is going to make a difference. But there are things like azithromycin, which is an antibiotic that people are trying to figure out if that's going to be beneficial. Hydroxychloroquine or chloroquine, people are trying to do that, but we don't have the data. And so a lot of it is it's compassionate use. It's doing the best that you can. And hopefully we'll be able to dispel the ones that don't work, and then hopefully have things in our toolkit that actually work. And I think relatively soon.
Great. Thanks for sharing that. I'm going to turn now to Dr. Thalia, since you mentioned her.
Mm-hmm.
Dr. Thalia, you're an anesthesiologist, and can you just, I know that at least at my physician, I had an elective procedure and it has been canceled. So I'm just wondering, in terms of your day-to-day, how has it been impacted by COVID-19 as a practicing anesthesiologist?
Sure. So again, thanks, Charlotte, for having me on. As you know, about a week ago or so, the governor issued an order to cancel all elective cases in the state of New Jersey. So it's been about a week now at Rutgers where we are only proceeding with emergent or urgent surgeries. So those would be patients with, infections or whatever the case may be that are threatening to their lives. And as far as how COVID has changed my day-to-day practice, for us, we automatically assume that every patient that comes in is COVID positive because, they're coming from the community. So in terms of intubations, we all wear PPE. We do things to try and minimize coughing, for example, on extubation, meaning when we take the breathing tube out and also when we put patients to sleep. So we, do a lot of draping with plastic to try and minimize any droplets because we know aerosolization of the virus contributes to spread. And as others have mentioned, there is great concern that there won't be enough PPE for workers on the front line. Right now, it hasn't been an issue for us at Rutgers. But I know that's something that we're, concerned about on a day-to-day basis, because for every patient that we intubate, it generally requires, at least 2 practitioners, if not more, to do everything safely. And that's a lot of, materials that are required as far as masks, goggles, gowns, gloves. I also now double glove for every patient that I see, which is something that I did not used to do in the past. So
that's interesting. So can you explain why are you double gloving and gowning?
Sure. So again, aerosolization. So the CDC has said that in terms of wearing things like N95, for example, and full PPE, those practitioners that are involved in procedures that cause or lead to aerosolization, so things like endoscopies or scopes, intubations, those are procedures where they advise clinicians to wear full PPE. So N95 is a mask that prevents 95% of particles from passing through. And in terms of gloving, you asked why we double glove. For the same reason, just to minimize risk of exposure to the virus, because we also know that the virus can live on surfaces for various lengths of time, depending on what the surface is. So it's just all a matter of precaution.
Thanks. And I'm sure when we get to the question and answer, someone will ask you about people wearing gloves out in the public. So I'll save that for then. Let's go to Dr. Janine. You're in the epicenter. I know Dr. Thalia is talking about double gloving. We are certainly hearing on the news that there aren't as many resources in New York and just wondering if you're feeling the brunt of that in terms of resources, PPE. Do you have that in your hospital? And then what are some things that you're seeing in your hospital in the South Bronx that you guys are having to do to accommodate the large number of infected patients?
Well, in New York State, we have become the epicenter. New York City has more than 2/3 of the new cases of COVID-19. And so we have a lot of mega centers in New York City that actually help to take care of patients. In Columbia, NYU, Mount Sinai, Montefiore. And those big centers are currently where our patients are rushing to. And so those centers are running out of PPE quite quickly. We are a community hospital, and so now we're beginning to see the overflow from those big centers. So many patients are now coming into our doors. And so right now our PPE is sufficient. We were at the border of running low, but then we had some very nice donations from people around the state. We've had some high schools donate PPE when they're in their labs. They use gowns and gloves and goggles. And so since schools are closed, some high schools have donated some PPE to us. Colleges have also done the same in the area. So we've been pretty okay with PPE. But like I said, some of the big centers, not so much. Governor Cuomo, the New York State's governor, has actually had meetings every day on TV talking about PPE and getting us different equipment that we need. And he has equipped us now. This week we had a big shipment of PPE, and many of the big centers have also had a big shipment of PPE. So far we're okay. As a pediatrician though, COVID-19 looks a lot different for us in terms of the children that we serve. As many of you know, many children are not severely affected. They do get infected, and many times their infections are asymptomatic or mild or moderate. Many times they don't require admission to the hospital. They can actually recuperate at home. So we haven't seen a lot of children entering the hospital. And in fact, many hospitals in New York City are shutting down their pediatric units to accommodate adults because it's been an overwhelming adult response to this pandemic.
Thank you for that. So I know that you had mentioned that you're now starting to see babies that come in with the virus. So it must, from a pediatrician standpoint, there are a lot of things that must be going through your mind as you are working with children, because some of them are immunocompromised just by their early immune system not being developed, their immune system not being developed fully.
Right, but some studies have actually shown that to be helpful.
Okay.
And they're saying that the inflammatory response that adults have to COVID is what is actually causing death and mortality and morbidity. And because children actually don't have that a heightened immune response that adults have, the thinking is maybe that's why they're being spared from this disease. And so we do see positive newborns. We have seen positive children, but more than likely they're at home recuperating. We're able to send them home and give moms and dads instructions on what to do if things become worse at home.
Okay, great. All right. So Dr. Ian, you are in the emergency room. I see all the images on TV of the emergency rooms in New York, and I'm just wondering what's it like in the Midwest?
Thanks for the opportunity to share. Ordinarily before the pandemic, I spent most of my time with 2 full jobs already. One as chairman of a pretty large department of emergency medicine, where I oversaw our clinical enterprise, which spans across Southeast Wisconsin, our educational endeavors to include medical students and residents and fellows, as well as our research enterprise, which is pretty large. Not to mention trying to develop individual faculty members' careers. But in my free time, I also serve as president of a national association that represents all the teachers and researchers in emergency medicine. So now I've layered on top of that crisis management around a pandemic that most of us have never seen before. We're all on the front lines, but I have to say emergency physicians and emergency departments probably are the tip of the spear and probably have been most impacted so far by this pandemic. It's fundamentally just changed ED operations across the country to include my own organization. I think yesterday was I know we're going to talk a little bit about wellness later, but yesterday was probably the first day I haven't been in the office in about 2 weeks or so. And as you can see from my backdrop, I'm back here again today. But it's really meant 16-hour days easily. I still see patients as chairman, so I'm intermittently caring for patients in our emergency department. And that experience has completely changed as well. So we work in an environment where we presume everyone who comes in is probably a PUI or person under investigation. And so what that's meant for us is we essentially wear PPE, the personal protective equipment, the entire shift that we're in the emergency department, whether we're directly in contact with patients or just working in a computer workstation. And for those who've worn PPE, mask and goggles and et cetera, it gets pretty hot and pretty uncomfortable. So to do that for 8 hours really is a difficult thing, but something that we found necessary. When we had our first, and we went to that because when we first, about 2 or 3 weeks ago, when we had our first cases here in Wisconsin, we had patients that we didn't expect to be COVID positive who turned out to be. They came in with, for example, stroke, and later on we found out they were COVID-19 positive. And so we went to a practice because we were losing some of our workforce due to those exposures to just presuming everyone is positive and using personal protective equipment. We've also, we've created a respiratory care unit in our emergency department. So it was formerly one of our observation units, but in an effort to try to cohort all these patients that we suspect, we've created a unit where we put all the PUI cases there, and there's even more personal protective equipment required. It's also changed. I think my anesthesiologist colleague can relate to this. One of the things that has really revolutionized emergency care over the last 10 to 15 years is the use of BiPAP, which is essentially a mask that gets fitted over the face and forces air into the nose and into the mouth. And it's used for conditions like emphysema or heart failure until we can treat the underlying problem. And it's a less invasive way of assisting their breathing. But because we know that that creates an aerosol, which carries the virus, it's really changed our practice, where now instead of using those, in which case we're probably spreading the virus to others in the emergency department, we're choosing to intubate these patients much sooner than we ordinarily would. And obviously that carries some risk. Like many other emergency departments, we're in a little bit of we've seen patients, but we think this is a little bit of the quiet before the storm, the storm that's happening now in New York and New Jersey. We do fully expect to come in the next couple of weeks or so. And so we've looked for ways in which we can increase our capacity. And so we've stood up tents at our various emergency departments in our health system as a means to expand the number of patients that we can adequately care for. So definitely not business as usual in most emergency departments around the country. I'll just leave it at that.
Wow. So you bring up a lot of improvising that you're having to do, the way in which things were, which you would normally treat patients or even approach patients, you're having to flex in the moment and really change things up because of what we're learning and what we know about this disease. It's very scary. I mean, the things that you talk about, but I can hear in it your confidence and just that this is what I signed up to do, and this is par for the course. So again, I want to thank you, you all, for your service.
Thank you. I think it's a really interesting time to be a physician in general, an emergency physician and an ID physician in particular. I think the outpour of support I've heard from people on social media I haven't heard from in years. And so that's been a real silver lining of this. We've also, and one of my colleagues on the panel, I can't remember which, we've had an outpour of donations from the community, because we've put at the university, we've put our labs on hibernation. They use PPE as part of their experiments, and they have packed it up and they've made deliveries to our various emergency departments. So there has been some really amazing goodwill. I've told my department, we've been compiling all these acts of kindness. I hope to be able to honor it in some way when the dust settles.
Yeah, that's great. That's great. So we have one more physician who I definitely want to make sure that we give a moment to just say, Dr. Abena, what your days are looking like. You know, one of the panelists mentioned that they do have research trials ongoing, Dr. Allison at Hopkins, and you are running clinical trials. So are many of our audience, because that's the membership that we have at Women of Color in Pharma. And just wanted you to give us a few minutes to tell us, you know, how has COVID-19 impacted your work day and the things that you're doing? Dr. Abena, are you there? Maybe she's on mute.
She's muted.
Yeah, let's see if we can get her off of mute. You're muted. Hold on, Lucretia. We see you. We're coming. Lucretia, are you working on it?
I'm working on it.
Okay, that's good. Maybe. Oh,
Okay,
there we go.
I
Good.
think I'm here now.
All right, great.
Okay, so yeah, I'm in a different position compared to, many of our colleagues here on a panel who are directly at the front lines of this pandemic. But it's quite interesting that this has global impact, as we have said before, and my position is also global. My work is really to ensure the safety and integrity, really, of clinical trials, and to primarily ensure the safety of our patients who are enrolled. So as we have seen this pandemic roll out, in other parts of the world, it has direct impact. Just like, physicians who are seeing patients in the office, we do have concern as far as the safety of our patients who are enrolled in trials, their ability to be seen by their physicians, and even their ability to have their study drugs continued without interruption. Many of them would be in dire straits if that were to happen. So this has been a time where it has been a requirement to be agile, to be creative in our thinking, and to act with speed so that people don't suffer. And I think these are tenets that everyone is using, actually, that we are in unique times and we really have to use all the resources that we have available in order to help people who will potentially be impacted and those who already are. So it's been a very busy time as we kind of troubleshoot to really act proactively, to make sure that we don't have patients who are in clinical trials fall into trouble as far as safety concerns or particularly interruption in their drugs. So it's definitely a challenging time, I think, for anyone. And I've seen it in industry as well.
Yeah, thank you for that. So, a couple of places I want to go next. I really want to get to the discussion that we had in terms of myths and what myths you all are hearing out in the streets, as you will, these days, and have you debunk the myths. But then I also want to make sure that we have an opportunity for you to just share, what is it like to be juggling your home life now that you are really on the front lines of this pandemic that's changing very rapidly every day. And Dr. Ian, you mentioned that you're in the office, 9 o'clock on a Saturday morning. I'm not sure if that's your normal, but this pandemic has certainly seeped through all aspects of our lives. So why don't we quickly have maybe one or two, three of you talk about the impact of this pandemic on your home life and what it's like at home. And we think that there are probably good things and not so good things about it, but if you could just talk about it, that would be helpful. And then we'll shift to what are some of the myths that you're hearing.
I'm happy to jump in first, as I have my whole family quarantined, so I could do the webinar downstairs. So, so it's a household of 4 here. So I have 2 kids who are clearly out of school, 10 and 12. And so, as many of you on the call are probably juggling your work life and then now homeschool teacher and scheduler of all things and activity planner, et cetera. So that's been one. I think also when everybody's out of their regular routine, there's a lot of angst and anxiety. And so becoming a mental health therapist on top of that for my family. I think also going into the hospital and at times interacting in spaces and places. And we know healthcare workers have a higher rate of acquisition of the virus, just facts. Recognize that there's some anxiety that me coming back in the home may bring, and having my partner be like, I'm going to be on the couch, Allison, because I think we should have some social distance within the home, right? And navigating that. So, I mean, I think there are many pieces. So juggling, it's even if you're working from home, it's all day calls, it's command center, et cetera. So you're not necessarily available, but trying to attend to all the different aspects. I'm also one of the people who's taking care of an elderly mother. And so trying to, drop by, I wish drones were active that I could drop shipment because I'm worried about, infecting her, but wanting to make sure that her needs are met. So it's constant, just trying to make sure you're doing the right thing in the right space and protecting people as you need to recognize that you are at higher risk individual.
Mm-hmm. Yeah. So you're homeschooling?
I am attempting to homeschool. I'm not very good at it.
Yeah.
But I do give kudos. No, we have a schedule including 4 to 5 hours of recess, limited video time. I mean, really trying to make sure, use it as an opportunity to often complain about what kids are taught in school. So use it as an opportunity to enhance what they learn and essays and thinking. So I'd love to hear what they think about it. They'll be on somebody's couch someday complaining about what their mom did to them during the pandemic. But
so this is Janine, and so I can sympathize with Allison. I have 2 daughters as well, 8 and 12, and they're also at home now during this time. And as a physician on the front lines, one of the first things I do when I come home is strip and go take a shower immediately and wash nose, my mouth out, so that I am not infectious towards them, because we live in New York City. So we are in an apartment. And so there's not much social distancing that I can do from them living in an apartment, and not living in a rural space or an urban space. Getting outside for them means public spaces. So public parks and public spaces. And so we try to make sure they get outside every day. We try to go to a space where we don't see a lot of people. Yesterday we went to go play basketball and Black people tag. So that was a very interesting experience, and also juggling the homeschool experience with the teachers and the teachers knowing about technology and how to initiate the teachers into this new phase of technology. So it's a very interesting time. I too have an elderly parent, and I haven't been to her home in 2 weeks. I order her food via the internet so that I know she has food. I know she stays inside. But it has been a difficult time for all of us, I believe.
Anyone else want to jump in here? I know, Thalia, you have small kids as well.
Yeah, I have a 6-year-old and an 8-year-old. So, I mean, I echo the sentiments that were just shared. It's, in addition to going to work, like at the hospital, I also have to juggle the school life of the 2 boys in terms of, lots of emails to teachers, just staying on top of assignments. But I would also say one of the biggest things for me that has changed is the first thing that I do when I get home now is basically decontaminate. Before I would come home and, not worry about my scrubs. That's not the case anymore. As soon as I get to the door, like I immediately change and shower before I do anything else, just because of the concerns of, spreading virus to people in the home, getting it on surfaces. So I would say that's another way that life has changed for me. And I've also opted, I mean, I know they say that, eating out is fine, but me personally, I've just opted to not like order out. one of the things they mentioned in China, for example, is a lot of the takeout food industry workers there, they're all monitored for as far as their temperature. And that's not something that we necessarily do here mandatorily. So I know that's another way life has changed for a lot of people.
And we're talking about kids, but you know, kids also, in addition to their education and needing homeschooling, needing to eat. So has any one of you like started cooking more than you've been cooking previously? I know I'm in the kitchen every day now, which is killing me.
I think even pre-pandemic, I taught my kids to cook. So I cook on my schedule, and if they want to eat other things, they are also cooking. So that's been good. So that hasn't changed so much. You know, shopping has been crazy just because trying to get what you need and avoiding the madness at the grocery stores, et cetera, has been challenging. But I think it's been an adjustment.
Yeah. Okay. Well, why don't we shift? Because I definitely want to give our audience an opportunity to ask questions, but I really wanted to shift and talk a little bit about some of the myths that are circulating regarding COVID-19, who can get it, who can't get it, and was hoping that you guys would just jump in with whatever myth you've heard and then give us the facts.
Yeah.
Ooh, I'm just going to put this out there and I'll let the experts attend to the answer. But Black people can't get it is the #1 myth that we need to bust today. And I will invite my colleagues to break it down as far as what we're seeing.
So I think Idris Elba and the NBA fixed that, you know, as we started to see, right, more people get infected. I think part of the challenge with, and I'd love to hear what other people have to say, is, you know, I think Africa was dancing. There were all these memes like, oh, look, it's not affecting Africa, the epicenter of Black people. There also is not testing, right? And so I think we have to be careful. Black people certainly can get it. We're seeing Black people get it. You know, again, we can potentially talk about access to testing, et cetera, in terms of disparities that we may see in certain populations of who may be able even to test. But I think we can bust that today. We've seen Black people get it, and Black people need to take the same precautions as everybody else should be taking.
Yeah, exactly. And you know, Allison, before we move on and talk about whatever myth #2 is, you know, I just want to give a moment to talk about some of the disparities that we're going to see, you know, emerging in this pandemic. Anyone of you, I'm sure, can talk about this. Thalia, you sent me a very nice article this morning, so I'm going to ask you to just kind of tee up what are you seeing as some of the disparities that we will have to deal with based upon this disease, whether it's from a clinical standpoint or from a socioeconomic standpoint.
Sure. I wasn't sure, do you want Thalia or me to go? I wasn't sure.
Thalia.
Okay, all right.
Thalia. She can tee it up.
I posted an article in the chat. I don't know if people can see it. But basically, I mean, that the article does a nice job of highlighting the effect that coronavirus is going to have on our Black communities as a result of, you know, disparities in rates. For example, we know that our community has high rates of things like, you know, diabetes, heart disease, those comorbidities that tend to put patients at risk for experiencing the worst end of the spectrum in terms of COVID-19 symptoms. It's definitely gonna, you know, have an impact on our community.
Can I make a quick comment? So here in Milwaukee, which is actually a minority city, which many people don't know, but when we look at our heat maps around patients who were impacted most, we're seeing it on our north side communities, which is actually mostly African American. So for sure, African Americans can be infected and affected by this disease. Going back, someone made the comment about Africa. That's going to be interesting, you know. So the Southern Hemisphere right now is just going into their cooler period of the year. It's going to be very interesting because when you do look at the Johns Hopkins map, most of the cases cluster above the equator. It's going to be interesting to see what happens over the next 3 to 4 months as basically the southern hemisphere transitions into their cooler months. I suspect we're going to see the similar pattern happen in the southern hemisphere over the next few months.
Yeah, I would agree 100%. And that Johns Hopkins map is an excellent reference. And if you look at countries on the equator, places like Panama, tropical places like Cuba, Egypt, you know, there's some myths, or even we'll call them theories, that the virus can't proliferate as well in tropical or temperatures, and that map completely debunks that. I mean, Panama sits on the equator, and Panama is getting cases. Cuba's getting cases. We're starting to see cases in Tanzania. Burkina Faso, I think, is the highest number of cases right now in West Africa. And as somebody else mentioned, they don't have the infrastructure that we have in terms of testing. We think we have it bad here in terms of testing. In places like Ethiopia, you know, where the healthcare is essentially non-existent, they're certainly not testing. So that myth is I'll call it a myth at this point. I can't even consider it a theory that the virus cannot proliferate in tropical or warm temperatures.
Right, and that goes to the point that the virus needs a vector, right? So it's not about the climate, it's about having a vector in which to replicate in. And so if you have dense populations, you're going to have virus being transmitted to people that are in dense populations where the virus can replicate.
Wow. And
if you think we're crowded in New York, imagine what it's like in you know, Accra, Ghana, Addis Ababa, Ethiopia,
exactly.
You know,
Lagos,
Dubai, these places.
Cote d'Ivoire.
Yeah, they make New York look like the country.
Right.
Yeah, I mean, it has been said that the favelas of Brazil, and Brazil actually has the largest population of people of African descent outside of the continent, they will be heavily impacted by COVID because people are so tightly packed together, and they're just starting to see the first wave of the virus. And once it's out in the favelas, it's pretty much not going to be able to be stopped. So I think we have to be keenly aware of how our communities are impacted and be proactive.
Right. And I think another myth that we need to bust is that young people cannot get infected. That was perpetuated for a long time when this first started because of the studies that were coming out of China and children less than 19 not being hospitalized. But not being hospitalized does not mean you were not infected. And what we're finding is that children can be asymptomatic or have mild symptoms, but they also can be carriers of the virus. And in my catchment area, many of the children are taken care of by their grandparents or their great-grandparents. And so we have to be very mindful of that scenario that is out here, that young people cannot get infected by the virus.
I think to extend that a little bit, I mean, there's the young to the other 19, but then there's the 18 to 35, or et cetera, who are out partying, thinking that they're unable to have, you know, bad disease or to catch it at all. And that is to be debunked as well. While the risk of morbidity and mortality increases with age, we certainly have seen young people in their 20s come in and die with COVID. So we all need to take care and not think of just protecting against the older individuals.
yeah, that's great. Maybe we'll come back to any other myths that you guys are hearing. I just wanted to give a moment. You know, we are starting to hear that there are some medications that potentially, if you have COVID-19, you should avoid taking. Can someone just on the panel really speak to what you're advising your patients or even your family members who might have questions around what medications, you know, should they be avoiding at this time?
Well, I'll jump in.
Okay.
I think at this point, we don't have any data, let me say, we don't have any quality on what you should be taking and what you should not be taking. You know, we've heard things like avoid NSAIDs like ibuprofen, Motrin, Aleve, et cetera, aspirin. We've heard these things about chloroquine and hydrochloroquine. And, you know, other various things. I've heard vitamin C, you know, somebody sent me something about gargling. And I'm sure if we took a poll here, we've all gotten things or seen things, some in more reputable sources than others. But at this point, there's nothing that is proven in a quality clinical setting that would be available for our individuals at home or at your local CVS or Duane Reade that is going to prevent this or treat this. So it's very important that before you do anything in terms of prevention, you need to discuss it with your physician, as opposed to trying to self-medicate and, be Dr. Google.
Right, and I'm going to say it as a cardiologist.
Yes.
Our societies have had to come out with position statements regarding ACE inhibitors and ARBs. Those are the drugs that end in pril or sartan, and that there was some conjecture that, taking these drugs in both directions, that it might facilitate infection, that it might be protective. But the bottom line is abruptly stopping an ACE inhibitor or ARB that you might be taking for hypertension or congestive heart failure is a very bad idea. And in general, the risk of doing that is outweighed by any potential benefit. So again, like Jeff said, you really need to be discussing things with your physician, but right now we have no data to support that. God forbid, you were to do that and then have a stroke. I mean, I think that's kind of worse than COVID-19 at this point, right? So we really need to be prudent in terms of, there's a lot of information and misinformation circulating, and it's always good to check before asking.
I think I mentioned when we had our call yesterday that there's the WHO, the World Health Organization, has on its website a Mythbusters, literally a link. And so I think that's a good reputable resource for people to go to, whether it's about gargling warm water or whatever. They're hearing those and they're putting them on their website to actually provide information. So I think if people want to do that, to look at a place, go there.
Great. And I know we have lots of questions coming in, and I want to turn now to our audience and have them have an opportunity to ask you questions. I understand we have one person with their hand raised, so I'm going to ask Lucretia to take that person off of mute so that they can ask their question.
Christina Wright, you can go ahead and ask your question.
Oh, sorry, that was an accident.
Okay. So we'll go to the question. What are these doctors seeing first line in terms of staff being infected? Second part, are they seeing increasing numbers of staff getting sick? Final part, what advice do you have for expecting moms that are due to deliver very soon in these scary times?
Okay, so first question was around staff. I know we've seen on the news a lot of healthcare workers are, a couple have died, right? A couple of nurses have died. And then, so the question is, what are you seeing in your institutions around your colleagues?
I'll just chime in real quick. And I alluded to this a few questions ago. When we had our earliest patients here, we were actually caught off guard because patients came in with like stroke symptoms, and we weren't suspecting that they were going to be COVID-19 positive. With a couple of those exposures, unfortunate exposures, we had, some of our resident physicians, our faculty have to go into quarantine. Obviously, that has huge implications for the other folks having to fill in those gaps, including myself. So we went to the practice of PPE for everyone. And since we've adopted that practice, we've really not had any exposures since that time. I got to tell you, we have a daily task force that meets. I am most worried about this particular issue. We are in a good place right now in our state and at my institution, but I have many colleagues in New York, Columbia, NYU, and seeing this pandemic through their eyes. And I think the PPE is potentially the single point of failure, at least for healthcare workers. So it's the thing that keeps me up most at night. And we are hyper vigilant about looking at how much are we using, how much do we have, how can we conserve those, because it's really important to keeping the healthcare workforce healthy.
Yeah, I can speak to New York. Definitely, we are having challenges. We had some of the same similar instances as Ian, with not knowing in the beginning that this was COVID-19. We had people coming in with asthma attacks, and in the Bronx, we have the highest rate of asthma in the country. So our thought was, oh, this is a simple asthma attack, not knowing that it was exacerbated by COVID-19. And then as we learned more, we assumed that everybody now had COVID-19. So we had a number of exposures, a number of healthcare workers out and trying to replenish that staff, while staff is recovering, has been hard. Governor Cuomo actually put out a call to action, and he invited healthcare professionals, so nurses, PAs, doctors, who had retired recently or let their licenses lapse. He asked for them to come back into the fold. He sent out that email on Wednesday at around noon. And by 5 o'clock that evening, 40,000 people from across New York State had volunteered to come back into the fold. Wow. So I think it's an amazing time to see what we are all capable of when the need is put out there. And so he's going to deploy those 40,000 people across New York State and focus particularly on New York City, where the healthcare workers are dwindling a bit.
Thanks. All right, let's move on to the next question. I understand.
Charlotte, you're on mute.
We have a question from Kimberly Gray.
Hi, so you spoke about healthcare workers being infected. Once they're infected and the virus has run its course, then when are they allowed to come back to work? How long does that, what does that look like?
You want to take that one, Allison?
Yeah.
Yeah, that's a good question.
No, I can. So I think one, you have to check what the local institutions' guidelines are. The CDC has guidelines that talk about 14 days or a certain time from the last symptom or last fever. And there's some variability because people are running into healthcare workers and just not having enough. So people are starting to tweak that a little bit, which I don't think is necessarily the safest thing to do. But in desperation, people are trying to say, well, they can come back with a mask 5 days post their last symptoms or 5 days post their last fever. Technically, really it should be 14 days and really 2 negative COVID tests, actually separated by at least 24 hours. But again, how people are actually instituting that, it varies by what they have available in terms of staffing. I'm not sure what other people are saying.
Yeah, I'd agree. And what Dr. Allison just mentioned is sort of the overall expert from the CDC and the WHO. But there's also various guidelines by state and in hospital. Like here, I'm working with 3 different hospital systems, 2 of which are based in Virginia. One is which is based in North Carolina, but has a presence here in Virginia. And they actually have some differences in their return to work guidelines.
Okay, we're going to take
no symptoms for X amount of time. And
Right.
I've heard at least 1 negative test and potentially 2 negative tests. Right. But there's also some confounding issues with that in terms of how, just how good is the test, how sensitive or how specific is a negative test. And that's still being worked out with the science right now.
Right. And then
so I'm going to take a question from the chat. Can we have one of our panelists answer, is the virus expected to slow in the summer and surge in the fall?
I'm happy to take that one. I think the answer is we don't know. Right. I think there's certainly all viruses where there's some seasonality. We tend to see flu more in the winter months, and then it varies in the summer months. But I think this is a novel virus. We have not seen it before. So I think we'd love to say we think that it's going to have some seasonality to it and it's going to burn out, like I think 45 said. But I don't know that we can say that. I think predictions now in some models that maybe by June we'll see some decrease, et cetera, but I don't think we know. So if you ask me, I think we're looking to months of this, not to have people be freaked out, but I think we can't say. And so we're anticipating in the ID community that we are going to be at this for quite a bit longer.
Thank you so much. We have a question from Latrice Grisby. Go ahead and ask your question.
Hi, good morning. First of all, thank you for putting together this forum. I think it's excellent. I don't want to be selfish with the questions, but I do have 2. First of all, you mentioned that this virus is going to affect our community at a disproportionate level, or could affect our community at a disproportionate level. My mother recently had some symptoms that I thought were very similar to what was being posted on the website, on the CDC website. And she is a 3-time cancer survivor, and she had a stem cell transplant. I'm wondering, are people of color being, I don't want to use the word, I'm going to say the word, disproportionately affected when it comes down to testing? She was not offered the test. She went to 2 different providers, and was kind of toggled back and forth between the system, but was never actually offered the test. So do you see that being an issue for the African American community, that we could somehow be disproportionately tested or not tested?
Certainly, I can address that one. So let me just say first that, you know, your mother is a stem cell transplant patient. For those that don't know, stem cell transplant is a bone marrow transplant. Essentially, when you get bone, you have typically a very advanced hematologic malignancy like leukemia or lymphoma, and you get stem cells or bone marrow cells from another patient after receiving high dose chemotherapy. So those patients are, in fact, the most immunocompromised patients that we would see, outside of some other rare immunodeficiencies that are genetic in nature. So by definition, she is extremely high risk for COVID and all infections. Depending on when her transplant was, she still may be on antibiotics or antiviral therapies. She may be getting immunizations for other common conditions like measles and varicella, et cetera, because you have to essentially rebuild your entire immune system. Mm-hmm. So certainly if she has any symptoms of any upper respiratory illness at all, she will qualify for testing in any jurisdiction. Which leads me to the second aspect of your question, which is access to testing, which is more of a socioeconomic issue as well. If she's in an underserved area, she's less likely to be tested. We know across the board that people of African descent and people of color, including Latinx people and also Native Americans, historically, for reasons that obviously we're all privy to and are beyond the scope of this discussion, have been underserved. Anything that hits the remainder of this country hits our communities harder. So we would expect that in underserved areas, that something as serious as the COVID pandemic, we're definitely going to have some disparities in those outcomes. And we're probably seeing those already.
Thanks. Dr. Abena, I see you sitting on your hands. Is there anything that you want to say?
No, I mean, I think implicit bias is real. Yeah. You know, we are a panel of Black physicians. We are keenly aware, probably because of even personal experiences with healthcare. Everyone is not us. And this is frank. In my specialty, we know that people are treated differently based on how they look, even when it's indicated they do not receive appropriate testing and care. This situation is no different, and it requires us to be more diligent and to advocate for our family and friends and our loved ones if needed. It is a huge concern of mine, actually. We all know that testing is already problematic in this country. That is heightened when you add something like race and ethnicity to it. So we really have to, I think, be quite proactive. You know, your mom sounds like someone who, of course, we should have had a low threshold for testing. Maybe test scarcity played a role in not having access. But again, I would bring this up again, you know, because the stakes are extremely high.
Absolutely.
I also want to chime in on that to say that the guidelines for testing have changed dramatically over the time that we've been doing the pandemic. Your mother definitely qualifies for a test, so I'm a little disturbed that she didn't get one. But because of not having enough tests over the past month, the guidelines here in New York have changed dramatically. So we went from only testing symptomatic people who are hospitalized to testing symptomatic people who are on the outside. Now we're back to only testing symptomatic patients that are going to be admitted because of the lack of testing. So I think that also may have played a role in why some people get tested in certain areas and some people don't get tested. But definitely there is implicit bias in a lot of things that we see in medicine.
Right. I think the other piece to
thank you so much.
Yeah, the other piece to add is that reality is, as the testing revs up, hopefully these decisions that allow implicit bias, et cetera, to enter will hopefully be gone. I mean, you could just say, I want to test. And, you know, I saw today that Abbott just announced that they will be able to test. I think they're pumping out 5 million tests or something a day or something crazy like that, which will allow us to more judiciously get everybody tested, which is really what we need. When you look at the response in China, what they did was test everybody and then quarantine everybody, asymptomatic, who together, if they were positive, and symptomatic in hospitals, they're positive. I think that's part of what we don't have. And so, not to say, I mean, certainly every algorithm I know, your mom should have been tested, even if I look back several algorithms ago. So I don't know what happened with that. But certainly you're in the space to advocate with more testing being available that she be tested. So.
Great, thanks. So we're running out of time, but we have a lot of questions that remain unanswered. We're going to take one more from someone who has their hand raised. Lucretia?
Monique Adams has a question.
Hi, everyone.
Monique, are you there?
Yeah, I hear her.
Okay, can you guys hear me?
Yes.
Yes.
Perfect. All right, so I wanted to thank all the panelists. This has been very informative. One of the things that you guys definitely shared during this global pandemic crises about the changes that immediately that you have made to how you practice. And I'm wondering, what do you think will be the long-term effects so that once we move beyond this, what do you think will be the impacts in terms of how you practice medicine in the future? So like what impact it may have as far as telehealth or, direct to patient or virtual visits? How do you see as what you think potentially may be the long-term effects of this?
I can speak to that. That's an excellent question, Monique. So I think at this point, the genie is probably out of the bottle for better or for worse. So, in terms of telehealth, telemedicine, that was something that was slowly grinding along, at least in the private practice community, for more so for payer and insurance reasons. But, now we've shifted within 1 to 2 weeks to going to where every payer, Medicare is also accepting telehealth. It's convenient. Yesterday in my clinic, I probably saw about a quarter of my patients via video visits. Obviously, it's a challenge when you're treating some patients who have to physically come into the office and receive treatments. But for those that don't, just a review of anemia or a review of blood pressure or diabetes. We have virtual diabetes monitoring now as well. So a lot of these things can be managed virtually. And just because of this pandemic, we've sort of been forced down that road for safety reasons. But I think now it's probably going to be difficult to, like I said, put the genie back in the bottle. And I think it will be something that is potentially beneficial to a large portion of our patients.
Great, thanks for that. Actually, Ian, I see you wanted to say something. Go for it. Can you take Dr. Ian off of mute? There you go. Yeah.
I'm happy to move on to the next question if that's what you were going to do.
Yeah, I was. One question came in about, is it true that you build an immunity to COVID-19 after having it once? So I want to see, Allison, maybe you can take that question real quick.
So we do know that there have been cases of people who have tested, who have been known COVID and then have acquired it again. So I don't think we know enough. I'm wondering if it's going to be something like the flu or certain things where you see it and your response may be less. Next time you see it, you may have a less robust response to it, but you certainly can get infected again. I just don't think we know enough. But right now, the thought is you can potentially get it again, and so you shouldn't act as I've gotten COVID and I can't get it again. I'm free to move on.
Okay. All right. And then the final question I'm going to ask, because I know this is something that we wanted to really discuss here. What is the psychological impact on people, and what should we be looking for in terms of mental health or trauma related to pandemics? What do we know? What have we learned from past experiences? So Jeff, do you want to start there in terms of psychological impact, and we'll have our other panelists chime in?
Yeah, absolutely. So this is something that we talked about yesterday. Just speaking to our mental health colleagues, our social workers, psychologists, psychiatrists, we're seeing an uptick in patients and providers having anxiety disorders around the pandemic, which is not necessarily an unnatural thing. And let me just preface this by saying I'm not a mental health provider. But this is when we speak to our colleagues in those spaces, we're seeing those patients start to come in. And this is a natural response to any other disaster that we see, whether it's gun violence, whether it's war, fears about crime, et cetera, plane crashes. So I think it's important, especially in our community and, you know, people of African descent, there's been a stigma with reaching out to mental health providers. That stigma, that wall is starting to be broken down, thank goodness. But I just encourage everybody that if you have anxiety in and around this, that it's beneficial to seek out mental health providers, therapists, social workers, psychologists, and just talk about it. Me, from a personal perspective, I've just been concentrating on, you know, making sure I'm practicing self-care, really focusing in on getting 7 to 8 hours of sleep, which for all of us busy professionals, we know is typically not what we get. But I've been, you know, focusing on that, focusing on resting, exercising, getting out, getting sunlight, staying hydrated, just doing the best I can to really practice self-care, mentally, but also physically. There's some data out there to suggest that, you know, when you're less stressed or so, your immune system is stronger and you're able to things of that nature.
Yeah.
Great.
I just want to speak to children about that, because
please.
Right now there are a lot of children who are very anxious about what's going on. They sit and they watch the news with their parents and they hear about death and mortality rates and people getting infected. And I encourage parents to pay special attention to their children at this time. Have conversations with them. They don't have to be conversations surrounding death and dying, but they can be conversations surrounding about their questions. What questions do you have? And how can I support you in this? Because this is a challenging time for them. Their whole routines have been changed around and upended. So I think it's a really good idea to do that. The American Academy of Pediatrics, its website, has information about dealing with anxiety in children during this time, during this pandemic. So I recommend everyone go to it and use some of the tools that they have available.
Great. That's a nice resource that you put out there in terms of the American Academy of Pediatrics. We will make sure to follow up this conversation with resources that we'll send to all of the participants. And I'm also, given that we are out of time, I am giving thought to having a follow-up with the panelists, maybe in a couple of weeks, because as you've all spoken about, things are rapidly evolving. So the information that we have today may be altered or have evolved in a couple of weeks. So we will definitely look into that. I know that given that things are evolving, we haven't reach the peak in the United States. You know, things may get worse before they get better, and you all may be too entrenched to come back during in a couple of weeks. We just don't know. But we will certainly keep an eye out, and if we are able to have a follow-up to this discussion, to really field the large amount of questions that our participants have. I understand there are over 30 questions waiting for us. Then we will plan to do that. I'll also be reaching out to you panelists to see if you could answer some of the questions, and we can just communicate them in an email. But I'm going to go ahead and ask each of you to just weigh in terms of, you know, what practical strategies have you employed during this time to not be on virus overload, if you will. So I'm going to start with Allison, and then we'll take it through each of the panelists.
So it's a little hard for me not to be on virus overload, but I think the practical strategies that I've had is I think Jeff mentioned it, is to give myself some virus-free time. So purposely unplugging, watching some random thing on TV with the kids, or engaging in a game of Just Dance, or just really trying to unplug, go outside, play basketball with the kids, go out with my partner, what have you, to make myself unplug. Because what happens is, if you entrench in it 24/7, you're dreaming about it and you never get rest. And so just forcing yourself to eat, exercise, pull yourself out for sanity.
Thanks. Dr. Ian?
Yeah, well, thanks for arranging this great panel discussion again. I think this is really, really important. When I think about the long-lasting impact of this, it's really around mental health, probably, and isolation. So as I mentioned earlier in the discussion, yesterday was the first day I didn't go into the office in about 2 or 3 weeks. And I just realized the day before that I sort of hit the wall physically and psychologically. And someone said, boy, you look really tired. And I listened to that, and I went home and got some rest, and back today better than I was earlier in the week. So I think you got to turn TV off. You got to turn the radio on, listening to some mindful music. I think it's important to also connect with family and friends. So it's actually been really nice. We've had, in my own family, we've had these family nights where we get on, whatever the tool is to allow people to see each other and remain connected. I think that's been really important. When you think about the members of your family, particularly those who are elderly, who may already be sort of isolated, but are so much more so during this time. So I think it's important for us to look for opportunities to be connected with our family and with our friends, despite the challenges before us.
Great. Dr. Janine?
So I also too try to practice mindfulness. And so with that, I remind myself of Psalm 46, verse 10, be still and know that I am God. And I repeat that psalm, that verse to myself regularly, and I'll break it down and say, be still, and I'll be still. And then I reflect on the fact that there is a higher power who has control over all things. And I repeat that to myself, be still and know that I am God. In addition, at home, we have a nightly devotional, my husband and my two daughters, and we go over Psalm 91 as well. And so I think just being mindful and understanding that there is a higher power who is in control, and we too will get through this, is something that has been very helpful for me.
Yeah, thanks. Jeff?
No, I agree 100% with all the other panelists. Well, actually, Charlotte, this was fantastic. So thank you for getting this together. I'd be remiss if I didn't get that out there. But really, self-care, for those that are on the front line, and Thalia, Janine, everybody, you guys are on the true front line of this. We have to protect ourselves, because if we're not there to provide care, then no one else is. That's the first thing. The second thing, for me is just there is a fire hydrant, an overload, a waterfall of information out there. I'm getting, literally 20 emails a day from 10 different people. And I just want to encourage people to, find a quality resource, a quality source. You can start with the CDC. Another excellent source is your state health department. And just inform yourself, because when you have information, you're able to debunk some of those myths out there, and that also can put your mind at ease. As human beings, what we fear is the unknown. And there is an unknown component of this, because we're managing this and researching this in real time. But when you're able to be informed and have the data there, you can put yourself at some ease.
Great, thank you. Dr. Thalia? Are you there? I'm trying to see if I see her. Oh, you're on mute. Let's go to Abena, and then Lucretia, if you could unmute Thalia.
Yeah, this has been wonderful, as everyone has said, and Dr. Janine was preaching. I think it's very important to stay centered and grounded in times like these. I would say one thing is to also look for the silver linings. I was lamenting about, honestly, 2 weeks before this pandemic really started to take off in the US, that I didn't get much time with my son, who's almost 3 years old, during his waking hours. And here we are. I got him all day, so.
Better or worse.
Be careful what you wish for.
So there's that. But, this is an opportunity to also reflect on many things in our life, like others have stated, to reconnect. When D Nice did his party, I'm telling you, last weekend was the best that I felt in a long period of time. And it was good to just, listen to some music and to be uplifted. We still need to look for the bright spots.
Right.
Yeah, absolutely. That was great. For those of you who don't know, DJ D Nice was on Instagram partying continuously, nonstop. There were so many people who were joining him. So we're having a hard time getting Thalia off mute, but I'm going to go ahead and end the call, because I know we're a couple minutes over. I just want a couple closing remarks that we will have this recording available after this call, you will get information about that. It will be publicly available on the Women of Color in Pharma YouTube channel. So please look out for that and share it with others. We will also take the questions that we weren't able to get through and figure out how we can answer, get answers to those. And we will look to see as things evolve, if we're able to get this group of physicians back together again to do a Q&A session with everyone. So thank you all. Have a great weekend. Please take moment to unplug, turn off your TVs, and just enjoy some personal time with yourself and your families, and stay healthy and be well. Thank you.